Thanks everyone, thanks for your patience staying this late on a Thursday afternoon. I think it's soon time for a pint or a beverage somewhere, but I hope you'll bear with me for the short time I'm here to talk. I want to thank the IGHN for inviting me here, and in view of the important and insightful contributions over the past 2 days, I gave the, rapporteur session yesterday under all the A's. I'm up to 18 A's now, you'll see them in the report, focusing on advancing health equity, health system strengthening, human rights, social justice, decolonisation, partnership, role of networks, stigma, mental health, building resilience, during conflict and climate change. And when I was preparing for this, I came up with my own simple sort of acronym for health based on this conference. I like words. So H is about humanity. And those of us who've worked on the front line of health, I'm a nurse midwife, as Delroy said, there's nothing better than protecting a life. Somebody coming in, being diagnosed, being treated, curing, and going home. I mean, that is the best part of working in health service delivery. Thankfully, all the people who do better and go home. So health is about humanity, and everybody here, is part of the humanitarian community. The E, equity, the last session, I don't need to say any more, but it's equity, advocacy, and action leading to health for all by 2030. We've only, I think, 5 years left, and we're not doing too well on SDG 3 in terms of 25 million children still needing vaccinations, underserved. A woman dies every 2 minutes from perinatal causes related to pregnancy. Being a midwife, that disturbs me terribly still. And in terms of the malaria cases surging globally, worldwide, with climate change. For me, as Professor John Kevany said, the main driver continues to be extreme poverty, inequality, urban and rural poverty, gender especially, and economic inequality, injustice in terms of low access to essential quality primary healthcare services, all amplified currently by climate change, conflict, humanitarian crisis, with a breakdown, as I see it, in community networks, increasing right-wing conservatism, right-wing agendas, assaults on human rights that I did not see 35 years ago starting in this work, and gender progress being eroded in too many places from Afghanistan to the USA. I can only talk about my personal, humble, local to global health journey, and like I say, I remain a practitioner firstly. I grew up on a farm in County Wexford, taking care of sick animals with my mother, baby lambs, baby piglets. I think it helped me and was a foundation for this work when I went to the Mater Hospital to train as a nurse. My great teacher there, who believed in teamwork for all the heart work, some people will remember him, Mr. Morris Nelligan. He was my hero at the time, the first person working in open heart surgery. That's nearly 40 years ago, imagine. I was a child then, I think. From the Mater, I went to the Coombe to do midwifery training, because at that time people said, oh, you have to be a midwife as well as a nurse to work in Ireland. So again, looking back, I think it was the most important training I received from my overseas work in terms of learning about antenatal care, safer delivery, postnatal care, and all the issues that go with it. In St. James's Hospital, some people here know and remember I worked on the hospital unit at the top of one. Very sobering experience at the time. First time I'd come across HIV and AIDS, seeing young people dying of AIDS, no treatments available in Ireland even then in the mid to late 80s. Like I wrote in an article a few years back, I'll never forget 2 young hemophiliac, blonde, handsome young brothers dying of AIDS-related illnesses from infected factor VIII received from the USA. And too many other people then who had contracted HIV in different ways. The secrecy was challenging, the stigma, discrimination. Many people hid their status, preferring to say they had leukemia or cancer, because the entire unit was the oncology, hematology, HIV and AIDS unit. So people preferred to say they had cancer or leukemias rather than AIDS. I got leave of absence from St. James's, really for adventure and travel, can't believe this, with Park Aer Lingus to work in Iraq during the Iran-Iraq war for 2 years. Again, I had never worked in a war setting, and we were not directly a target, but unfortunately the hospital was located in the direction of Saddam Hussein's palace. So on many occasions the long-range missiles were coming in. We were evacuated. I was sleeping out during the day, but I never once did not go in for a night shift. I guess it's the naivety and I guess, survival, innocent, youthful naivety, I think. But that's not what struck me most about Iraq. I traveled the whole country, you could then. Went to Basra, Kurdistan, Syrian border, and I saw young girls limping, a bit like I'm limping now for a different reason. But I went, well, what on earth is this? I'd never seen polio. In fact, it was seeing polio got me into this work, because I learned from the mothers, they weren't going to school, they'd probably never marry, there was a huge stigma, a technically 100% preventable illness with an oral vaccine, not even a sugar lump when we were kids, not even an injection. I mean, it really was incongruous, that I was working in this third level referral hospital, Swiss-built, beautiful, technologically, every way. I'd never worked it, and since have never worked in anything like it in Ireland. But meanwhile, children were, and I was only seeing the children that survived with the limp. I didn't see all the children who died of polio. When I was back in St. James's, I did another 2 years on the top of one before I joined Concern Worldwide in 1988 to do what many teachers, nurses, engineers, people do in Ireland. I'd go for my 2 years and get my job back. That didn't happen. I wanted to go to Somalia, actually, to Mogadishu, because I'd looked at Mogadishu and saw that's on the ocean, good swimming, nice climate. Didn't know about the conflict in Somalia back then. I ended up in the desert of Sudan, because that's where Concern wanted me to go, in the Blue Nile province in Dindar district. And it was a revelation. I quickly realized I'd have to learn Arabic. There was nobody speaking English in the Blue Nile province where I was working, to work with midwives, nurses, vaccinators, community health workers. I'd never heard of primary health care, so I booked myself into, some people here might know it, Wad Medina University, Irish Aid was supporting it at the time, to learn about primary health care, which at that time from Alma-Ata 78 to 88 when I started had 8 elements, and everybody here knows them, so I'm not going to read them. But then, thankfully, since Astana, much more focus on oral dental health and mental health. I had 2 books with me at the time in English, Where There Is No Doctor. I read it twice. Helping Health Workers Learn. I read it twice. Wow, primary health care, what have I got myself into? But I quickly realized, and some people have mentioned it here, why aren't we doing this in Ireland? This is what it's all about, primary health care. Health education, promotion, and illness prevention. Like I think Dr. Brendan said, we're moving towards that in Ireland, but I don't think we've got there anywhere sufficiently yet in terms of effective primary health care support and implementation in Ireland. I first saw the 10 elements, I first saw in Sudan, which I'd never seen before, frightening, I'm scared, rabies, snakebite, tetanus, lockjaw, babies dying of tetanus, neonatal tetanus can kill. I remember the sheer excitement when we managed to save some babies from neonatal tetanus lockjaw because they can't breastfeed, using pipettes, if anybody who's worked in a hospital. And it was a miracle when small babies survived, most died. If I can get back to Sudan anytime soon, sadly not with the current conflict, I want to recommend the head of the midwifery school, Sit Noura, for the Nobel Peace Prize. She managed to convince the sheikhs in the villages where I was working that it would be better that they would allow the untrained traditional midwives to be trained for safer antenatal care, safer delivery, safer postnatal care, to reduce female genital mutilation and all the other harmful traditional practices that I saw there that to this day I don't understand what some of them were. I really would need to talk to an anthropologist. I'd never heard of FGM, and Akidwa Salome mentioned it yesterday. Took me some time as a midwife to even understand what I was seeing. the different types, the dangers and the impacts. And every single woman I saw in delivery in Sudan was pharaonically circumcised, the worst type. I saw or heard of a woman who died every week in childbirth. I'd never seen that in Ireland. Nothing can prepare you for it. I hate to say it, it's awful to say it, it's offensive, but when a woman dies at home in a mud hut from postpartum hemorrhage, it's an abattoir. It's awful. And even the team working with me, we just couldn't deal with it. And like I've learned since, and we all know, most and majority of maternal deaths are entirely preventable. After the coup in 1989 in Sudan, I was able to get back. I did 2 years. I wanted to join for a third year. I came home to Ireland for family issues, and Sudan cut my visa. The government wouldn't let me back at that time. I was raging, furious to think that the midwives and vaccinators thought another little, short, white aid worker had enough and just went home. That was totally untrue. I never even packed my bag. I never got back at that time. But based on what I'd learned there, I wanted to stay in Africa. Concern sent me to Cambodia. A much harder language to learn, Khmer, it's tonal. I was based in Kampong Spu. Again, Khmer language, was essential for my protection. The war hadn't ended at the time. And as well as doing the formal assessments, we need to do holistic assessments like, to me, the best ones are walk about and talk about. Talk to everybody, not just people at formal meetings or sessions like this. The people making the chai in Sudan have all the information. The local drivers, everybody. The endemic health issues in Cambodia included malaria, dengue hemorrhagic fever, landmine accidents almost every day. The first woman I saw die in Sudan, sadly, was a woman who died in childbirth. I talked to her the day before. She had a transverse lie. She'd asked me to palpate. I knew it was a transverse lie. I said, please go to the hospital. There was fighting overnight. Khmer Rouge was still active in the area. She was in an IDP camp. She didn't go to the hospital. I was back in the camp next day. We weren't allowed to sleep there at night like in Sudan. They handed me the surviving baby, and I found out that the woman had died. It was absolutely shocking. We need to put people first, and 3 minutes, oh my God. I first heard of HIV and AIDS in Cambodia, and when I went to do my master's for my thesis, that's how I ended up in Tanzania, working on HIV prevention among adolescents and young people, education needs for safer behavior. And the slide the theory of change that I did in 1994, that's 30 years ago, is almost as relevant now as it was then in terms of the barriers, the socio-determinants. It was supported by GTZ and PSI at the time. And I'd had hoped to work in an English-speaking country after Cambodia and going to Tanzania. I ended up going to Mozambique. Another language, everything was in Portuguese. At least I could read it, ABC. But, I never spoke Portuguese as well as Arabic or Khmer. There are 60 dialects of language in Mozambique, 60. Everywhere I worked, we worked on the 6 building blocks, again, focusing on the demand and the delivery side for access, coverage, and equity. There are no shortcuts. Investment is absolutely critical. Conflict is and can collapse health systems, as we see in Sudan currently. And attacks on healthcare workers are worse last year than ever before. Health workers were not a target when I started this work in Sudan, even in Iraq, Cambodia, Mozambique. Now health workers, health facilities are targets. Print that report, it is shocking. Safeguarding health, like I said, peace is the best medicine for protecting lives and health systems and livelihoods. In Concern last year, I was analysing the reports for 2023, a massive increase in zoonotic infections, infectious diseases, schistosomiasis, cholera, dengue, Lassa fever, measles, malaria. Over 60% of emerging infectious diseases are zoonotic. I totally support the One Health response, interfacing between animal health, human health, and the environment. I've been advocating on this in concern for nearly 10 years now. Hasn't been taken up yet. That's how long it can take, Robbie, even in your own organisation. But collaborations and partnerships are everything. And this is 10 years ago for us who were working in the Douglas HIV and AIDS working group then. We worked together for 15 years. We still need to call out our donors, our governments, a call to action. AIDS is not over yet. I'm sure Nadine and others will mention the Father Michael Kelly lecture coming up in December. We heard the stats, 4,000 adolescents every week, nearly 3,500 new infections globally every day, 3 new infections every day diagnosed in this country in Ireland. HIV is technically 100% preventable. I want to thank all the partners here I've worked with over the years, Concord, ICFA, DOCUS, Access to Medicine Campaign, ACT UP Dublin, HIV Ireland, ESTHER, DSAI, RCSI, and more. Health remains our primary asset at family, community, country, and global level. We need to value it as an asset. We need to convince governments to invest in additional human, medical, financial resources. I think I read a stat yesterday. The World Health Organization says that we're short of 4.5 million nurses and midwives by 2030. We're not investing in the people who do the work. We saw it with COVID-19, the vaccinators, the community health workers, the nurses, the midwives, the district doctors. The district level for me is the fulcrum of the health centre, health service, delivery and demand. If it can work at a district, we can, we can amplify to a country, but we need to help districts to function and deliver. I'm just back to the acronym, what is health? It's about this. Thank you. Thanks for your attention.
No, thanks so much, Breda, for a wonderful lecture. And isn't it so inspiring to hear a career so well spent, and yet the enthusiasm still after all those different adventures and everything you've done in so many places, still the passion, still the enthusiasm. That's wonderful to hear. So we just have time for probably 2 very quick questions. So we'll open the floor.
Hi there, Breda. Thank you so much for this lovely summing up of your career. We met 24 years ago in Ethiopia, and we've met many times since, but it's always a pleasure to hear you speak. I'm a health systems researcher. I've become a health systems researcher, and I'd love you to comment on why we don't spend enough time, money, and focus on health systems when, at the end of the day, you know, what you've just put up, what is health? Health systems is health. Without a system, there's no health. Why haven't we been able to do this in Ireland or globally?
I'm still trying to figure that out, to be honest. But I think it's the complexity in terms of health. I have it here somewhere. Like, health is a number of mini systems. You know, you have logistic systems in health. You have the transport system. You have the supply chain system. You have the human resources system, you have the governance system, you have the financial system. It's a multitude of mini systems to make a very complex wheel that's unwielding. We haven't worked it out in Ireland. We're investing more money, but we don't have efficiencies or better outcomes, because I would say in Ireland, you know, we don't have a healthcare system, we have an illness care system. You enter the system when you're sick or late diagnosis. The costs are greater. The chances of morbidity and mortality and long-term disability are higher. People think, oh, health is easy. You know, health is not easy. It's so complex, and we need to get our donors and governments, and like I say, health is wealth. There is no development without health. And we'll sadly see that with the next pandemic. And, you know, zoonotic infections, HIV started as zoonotic. COVID-19, now they changed the name, Mpox. I mean, what's the next one? I don't even know. But yeah, and it's harder to convince people. You know, people put up ads, the recovered baby from malnutrition, the child maybe that didn't get polio, but that's harder to sell even. How do you how do we orient people into, what does a good health system look like? I'm still looking for the best. I've heard about Scandinavia. I think I better go and visit you in Finland.
Thanks. We have time for one last question. And if there's no hands, I'll take that privilege myself. So, Breda, that was a fantastic run through your career, a varied career. In 2024, maybe the world has changed. I don't know. What advice would you give some of the enthusiastic younger people here who are, be they healthcare workers or pursuing other careers, but want to stay involved in global health, want to make a difference in global health throughout the rest of their careers? Where should they start? What should they do? Is there a path to follow, or what would you suggest?
I think nothing can beat living and working in communities. Luckily, during my first sessions or overseas sessions, even in Iraq, despite the insecurity, we were allowed to travel the country. I know the madness of it. Get on trains to Basra and up to Kurdistan, and hopefully the missiles won't hit us, even though we could hear them at times. And in Sudan, I was able to sleep in the villages every night. Nothing beats working out in the community in the evenings, chatting. Then you get all the gossip. Language is the critical thing. All my learning has been knowing the language, Arabic in Sudan, Khmer in Cambodia, and saved my life. I actually wouldn't be here. Like the insecurity in Cambodia when I was there. Is anybody from concern here still? But, I was in situations I didn't even report. Getting caught in crossfire. The UN came to me for information, which I didn't want, because then I went, gosh, now I'm even more of a target. I want to be a lowly, NGO health worker. I didn't want that kind of attention. Keep embedded with the local community and embed yourself with the people who inspire you most. I didn't even want to go to the Coombe and do midwifery. But like I say, midwives are the community. They know what goes on in people's households and communities. Now, if I ever get to do a PhD, I want to look at the social, technical capital of midwives in their communities, in LDICs, because I think nobody can value it. It's totally undervalued. But babies are still being born as we're standing here today in Palestine, in Lebanon, in Sudan. Imagine the fear. I mean, I can't imagine it, the fear of trying to deliver in that context. So go with your passion, go with what you're most interested in. If you want to start in Asia, don't settle for Africa, really, even though I did the opposite. But I do advise interns, volunteers, write down which continent, what exact topic in health. If it's research, I'm not a researcher per se, but I've had to do some research. And USAID taught me rigor, proper baselines to end lines to be able to measure change, and then to see the satisfaction when I did see things improving in Mozambique, before the war broke out again. And certainly Bangladesh and Rwanda and more stable countries. It's reversing, sadly, and the countries compromised by conflicts that I can't remember anything like this, or maybe we just didn't have access to the media like we do now. Thanks.
Great advice for anybody seeking a path in global health in the future. Unfortunately, we are out of time. But before we finish up, Breda, I believe you're claiming to retire, but you're already mentioning doing a PhD. I'm not sure I fully believe it, but nevertheless, on behalf of the whole, the whole Irish Global Health Network family, indeed the whole, everybody involved in global health in Ireland, would like to make a small presentation. Thank you. A small presentation to you.
Thank you. Like I'm getting married or something. Thank you.
So, thank you so much, Breda.
Oh, we'll be able to come down.